theories. So again, if you think back to a lot of the neuroscience we had talked about in the past, and again, you may just, if things aren't clear, I would suggest kind of going back and maybe either just looking at that information, or bring questions to class on it. But again, it's kind of important just to kind of know, like things like the three neuron sequence of pain, how we perceive pain, when we do have an injury, to be aware of that stuff, because those things are going to come up as we're having these discussions. So as we look at the pain control theories, because these are important to understand, because when you're looking at modalities, we obviously know there's a lot of different modalities that can help with controlling pain. But there are going to be circumstances where, based upon how the pain control happens, where some are going to be more optimal than others, and there could even be circumstances where some, by virtue of the fact of what the modality has to do, they may be inappropriate to use. So that's why it's important to get to know this. Now, some of the things we're going to be looking at here kind of go back to some older theories, but again, what they kind of do is set the groundwork for the more modern ways we do look at this. So we are going to go back and review the previous theories, which again, we built upon these, and it's important to be able to distinguish what they are. So the pattern theory of pain was essentially back when we didn't really know pain receptors existed. So at this time, we haven't discovered that there were specific nerve fibers that were responsible for sensing pain. So the thought process with the pattern theory was that basically pain occurred when there was some level of sensory input that essentially exceeded a threshold level. So in other words, when you got hurt, it wasn't that you were stimulating pain fibers. What you were actually doing was just having all of this sensory information bombard the nervous system, and that's essentially how we then perceive pain. A couple of years down the road, we discover, well, there are pain receptors. So that then took us to what was called the specificity theory. So the specificity theory was basically, okay, now we have these pain receptors. Well, the thought process was, well, these pain receptors just link to areas of the brain, and then that's how we know where and how much pain we're having. So, for instance, if you injured your hand, there were specific pain receptors in the hand that connected directly to the brain, which, if you think about what we learned about how we experience pain in the earlier chapter, we discovered that, well, no, we have this three neuron sequence for pain, so there's a little bit more to the whole pain mechanism than we initially thought. So we ended up coming up with the gate control theory. Now, the gate control theory actually does relate to one of the modern day theories that we control pain with. We just kind of expanded it a bit. And the gate control theory came about, we discovered it through various things, but one of the ways we found the gate control theory worked was through the use of a traditional TENS, so transcutaneous electrical nerve stimulation. And that was basically one of the ways we help with pain relief through the use of electrical stim, by stimulating the large diameter afferents, or A beta fibers, and how that would interfere with the perception of pain. Now, so we will come back to the gate control theory, but that's actually been expanded upon. There's a little bit more physiology involved with it as far as how it controls pain, but nonetheless, that's a little bit more of a modern day approach to pain control. Another thing that was very important with pain control is the neuromatrix theory of pain. And this again relates back to the fact that beyond just structural damage, there's a lot of other things that influence how someone perceives pain, or what your textbook refers to as the multidimensional nature of pain. So there's obviously all the nerve impulses that occur by virtue of the actual physiologic response to the injury, but then there's also the visual input. So in other words, what the person sees in regards to the injury. Is there a bad deformity associated with the injury? Is there a big massive wound associated with it? That's going to impact the pain. The person's past experiences with pain, their cognitive evaluation, the emotional influences of the pain. So all that, motivational, affective, the sensory stuff related to it, all those things kind of impact the person's pain experience. So then that takes us into our different levels of pain modulation. Now, before I get into talking about peripheral pain, so just to kind of set the stage for this, there's essentially four different areas where we can either slow or stop the pain signal, okay, and assist the person with kind of controlling their pain. We can do that at the periphery, which we're going to talk about now, through the peripheral nerves. We can modulate it at the spinal cord level, okay? So we can actually stop the pain signal at the spinal cord level. We could stop it or decrease it at the supraspinal level, so up at the brainstem, and we could also slow it or stop it through a descending mechanism. Okay, so a descending mechanism we could actually get from the supraspinal level, going back down to the spinal cord and blocking the pain signal there. So those are the four areas where essentially we could either slow or stop pain. So we'll start with the peripheral pain modulation. So essentially desensitizing the peripheral nociceptors, and we had talked about this with cryotherapy, our immediate example of that. So in other words, with cryotherapy, we know that the nerve response to applying cold is to slow nerve conduction velocity. So essentially, if we're slowing the signal from the periphery, there's less input. So we're essentially taking that first order neuron, if you will, and slowing down the information from it getting sent to the spinal cord, and that's going to help assist in reducing pain. So that's an area where we can either slow or stop it with that cold application. Another reason why we look at the peripheral pain, the peripheral region being an area where we can modulate pain, is we know that when people take medications, they can act at a pain site. So in other words, there are receptor sites in the periphery for pain meds, and this can actually naturally occur with the endogenous opioids. So, we know about opioid medication, but the body also has hormones that act as endogenous opioids that are kind of the body's own natural response to pain. So, and one of the levels of pain we're going to talk about actually uses beta endorphins, but we know that at the periphery they can act as well. Now, there's some explanation with pain modulation. Certain modalities act at a subsensory level. So, for instance, when you put cold on, you could feel the cold. When you apply electrical stim, you could feel pins and needles. Well, there are some forms, there's even a form of electrical stim, which we're going to talk about here, of modalities that we have some evidence that they reduce pain. But obviously, if it's at a subsensory level, we're not using any type of sensory input to interfere with a pain signal. Microcurrent stimulation is an example of that. So microcurrent's a form of electrical stim that gets applied at the subsensory level. People, when they have microcurrent applied to them, if they feel anything, it's very minimal. It's not like what you classically think of with stim. And we know that we can reduce pain with that. Other examples of this are non-thermal ultrasound. So we know with non-thermal ultrasound, people don't really feel anything with it, but we have seen patients who do talk about pain reduction when they have non-thermal ultrasound applied. Laser and light therapy are other examples of that. So there's this subsensory level that can actually be utilized to help reduce pain. So we know that, again, that's probably likely a peripheral pain modulation when it gets applied. And where we kind of see some of the other things as far as peripheral pain, so the immune system, when it's challenged, so in other words, when someone has a cold or really bad cold or a flu virus, what's one of the things they complain about? They complain about muscle aches and pains. Now, there's reasons for that directly in those areas where they have that, but part of the reason why individuals are so sensitized to pain is the fact that when the immune system is challenged, it's basically allowing pain receptors to become more active. So that's again showing other chemical and hormone issues related to the peripheral pain modulation and how that could be impacted by other things. So we know that in the periphery we can modulate pain, and we know that obviously again in the situation when someone's sick, it also shows how pain can actually become a problem through that pain sensory mechanism. Okay, so looking at some other areas of pain modulation. So we basically then have, you'll hear these referred to as level 1, level 2, and level 3 pain modulation. So at level 1, we have what's called spinal level pain modulation. This takes us back to that original gate control theory. So the thought process here is that in the dorsal horn of the spinal cord is this, what we call a gate. And basically what it is, it's a neural mechanism that allows sensory information to be able to go up to the brain and get interpreted, and then the person can actually interpret whatever the sensory input is. Okay, and basically you could either increase or decrease nerve impulses from the peripheral fibers to the central nervous system. So essentially the idea here is, and there's some pictures in this that that are also in your textbook that'll help explain this. Basically, if you could stimulate large diameter A beta fibers, so the A beta fibers are your larger general sensory fibers, that they could essentially cause this gating mechanism, or you could, as they say, close the gate to pain through the dorsal horn of the spinal cord. So, again, people talk about this all the time. If you go to pick up something from underneath the table and you bump your head, what's the immediate thing you go to do? You go and rub your head. The idea is there is you're trying to stimulate the A beta fibers and interfere with the pain signal. So that's why when you bump your head or get hit in the arm, you immediately go to do that, because that modulates pain. The structure in the dorsal horn, and we'll talk about this a little bit more later, that closes the gate is what's known as the substantia gelatinosa. So, and that structure actually has, beyond just this very rudimentary gating mechanism that we talked about, we've discovered later on that there's actually more to that. That there's actually some chemical substances that get released that also block the pain signal. So that takes us to the revised gate theory, where we still have essentially the same mechanism at the dorsal horn of the spinal cord, but there's also some other descending signals that also inhibit it. And basically what we found is that depending upon how an injury is treated or something happens, we could either facilitate the perception of pain or inhibit it. Obviously we're looking at inhibition in order to be able to reduce the pain that one's experiencing. Your notes, I didn't put this picture in your notes. It's in your textbook, but this was essentially the original gate control theory. And again, not a whole lot's really changed, and from the perspective of the modalities you apply and kind of how they work, it really hasn't changed any. It hasn't made any major changes. It's just some things that we do want to talk about that are important. So if you look here, you have all your different structures. So again, your A delta and C fibers are basically your pain fibers. So the thought process here is that only one signal is allowed to get through. So when you have your injury, okay, or you have your trauma, your pain fibers are going to take that from the sensory nerve to the transmission cell in the spinal cord, up to the thalamus, the third order neuron, and then the brain's going to interpret it as pain. The idea here is that we interfere with the pain signal via the A beta fiber afferents, okay? So we apply some sort of modality or treatment stimulus that will stimulate the A beta fibers. The A beta fibers will connect with the substantia gelatinosa in the dorsal horn of the spinal cord. That will then close the gate, as we had said, to pain, and eliminate or decrease the pain signal. And that's essentially what you're looking to do with this level of pain control. Now, as I said, we have found some other, and I'll show this on the coming slides. This has been kind of advanced slightly, and we'll talk about what that is. And really, it's essentially one important thing that was kind of added to the process. Back to the same concept here. So you have, again, the A delta C fibers transmitting pain to the dorsal horn of the spinal cord. Ideally, what we're looking to do is somehow interfere with that, and I'll give some examples when I have a discussion on the next part of some of the modalities and how they work with this. But essentially, what we look to do is somehow, through some physical agent, stimulate the A beta fibers, and then that will then essentially, again, interfere with the pain signal. Now, where the advancement has, and you'll see it here, at what we've determined is that instead of just the substantia gelatinosa just more or less interfering with the pain signal and closing the gate, that what it actually does is it actually acts to release a presynaptic chemical called enkephalin. Okay, so we discovered an enkephalin interneuron in the dorsal horn of the spinal cord, basically in the region where the substantia gelatinosa is. And enkephalins are essentially they're basically, again, they're one of those natural chemicals in the body that help to reduce pain. So essentially what we've discovered is that in addition to this gating mechanism, which we're obviously still showing kind of happens, we have this enkephalin interneuron that also helps to block the pain signal. So basically what this does is it prevents pain signals coming in from the primary afferent from the, so for instance, an A delta fiber. It keeps it from depolarizing that second order neuron. It prevents it from getting to the transmission cell. So that's basically when the pain signal gets blocked. And again, the way this happens is through stimulation of the A beta fiber. So that's like kind of the whole key with this. That at level 1 spinal cord pain control, you're stimulating the A beta fibers. Now, what are some examples of the ways we do this with modalities? Well, one way is through electrical stimulation through TENS, okay? So sensory TENS, okay, so the stim, if you will, that where you feel, we didn't get in the stim yet, but that uses that pins and needles sensation, okay? That stimulates the A beta fibers and that helps to block, again, that pain signal. Certain types of massage will do this. So very light massage, okay, or a very light stroking massage will help to stimulate that as well. Mild heat can possibly contribute to this as well. Now, as we talked about, heat kind of gets pain from multiple areas, and we'll see that it's not uncommon for a lot of modalities to utilize different levels of pain control. They may use more than one, but even like a mild heating sensation, because that will trigger some A beta afferents as well, that will also help to block the pain signal. Looking at our other two levels of pain control, so our supraspinal and descending pain modulation. Now, a couple important things to note, and I'll refer back to this again in some of the later slides. Both of these, the supraspinal and descending pain modulation, do kind of to a degree work together, and you'll see that by virtue of what you're actually stimulating to get it. These utilize more of the body's kind of innate ways of reducing pain. So, the body has, for instance, its endogenous opioids and things like that actually are used just to naturally reduce pain. So when an injury situation happens, the body's kind of in a balance between alerting the person that there's something is wrong, but also at the same time trying to essentially calm them and reduce the input that they're actually receiving. So again, we obviously have to know that something is injured. We have to experience pain, but at the same time, we have to control that, okay? Because, and obviously when that doesn't get controlled, that's when you get people going into shock and things like that. So we'll talk about these separately, but you'll see how there are some kind of tie-ins. Now, there are some modalities and some applications that are more specific to one than the other, but sometimes you will get some crossover between the two. So at the first one we'll talk about is the noxious pain modulation. And noxious pain modulation is your level 2, and this has a greater focus on the descending mechanism for pain relief. So, and there's pictures that are also in your textbook that kind of illustrate how these work, and they kind of give you a little picture example as to how the pain relief occurs. So noxious 2 pain modulation utilizes feedback loops. So there's different feedback loops in the different areas of the brainstem, And what it essentially ends up resulting is a presynaptic inhibition at the dorsal horn of the spinal cord by virtue of the release of serotonin. So serotonin is a hormone that can help relieve pain and is very important in the descending pathways. Now, the key with this is actually this is turned on by stimulation of your C fibers. Okay, so your C fibers or your pain, which are pain fibers, are actually utilized to turn this on. So we will actually utilize modalities that stimulate C fibers in order to do that. And when I show kind of the pictures of how this works, I'll give some examples. But that's how we actually modulate pain through this mechanism. So now this actually still occurs at the dorsal horn of the spinal cord, but the mechanism is through descending input coming down from the brainstem. Rhythmical pain modulation is your level 3, and this involves rhythmic stimulation that increases the production of your endogenous endorphins. Okay, so again, this very much utilizes, more so even on a systemic level, the ability to reduce pain. And one of the hallmarks of this type of pain relief is that you actually get a prolonged pain relief. With your other types of pain relief mechanisms, essentially once the physical agent that produces the effect is removed, pain for the most part will come back much sooner, if not almost immediately. With level 3 pain modulation, you actually get a prolonged effect. It could actually act upwards to 6 hours. Okay, the key here is that you have to have some type of low frequency, high intensity stimulation, more or less from electrical stim. And when I talk about electrical stim getting utilized, all you have to know is the characteristics of it for now for what I'm discussing. I understand we haven't gone through stim yet, but to understand the pain modulation, you have to discuss a little bit about how it works. But essentially here it is to be a low frequency, high intensity stimulation that will actually cause a muscle contraction. This one is more specifically activated by the A delta fibers. Now there is still C fiber involvement. Okay, so level 2 is really primarily C fiber involvement. Level 3, mostly A delta, but C fibers, and there actually will be some descending mechanisms that will still occur, albeit again the key here is a more systemic pain relief coming from the release of endogenous endorphins. And then this last one, nerve block pain modulation. So talk about this a little bit. This is kind of a final technique. It involves decreasing pain through, again, basically reducing action potential. So this sort of utilizes, again, it's kind of the same idea of peripheral modulation, but it's a little different in that what it actually looks to do is create an action potential that actually produces an inhibitory effect. So essentially what you do is you apply a form of stimulation that will basically cause nerves to basically depolarize and have to reset themselves. So what this basically causes is a refractory period with the nerves that basically causes the area to essentially become anesthetized, because what you're doing is you're essentially causing the nerve to have to reset itself by the application of this. And the term used to describe it, and this will come up, and you'll see this term come up when talking even about electrical stim, called Woodensky's inhibition. So, and you get this the application of what's called Russian stimulation, or another type of stimulation called interferential. And this causes the area where you have your electrodes when you're applying this form of stim to basically become anesthetized and produce analgesia. Again, the idea here, though, is that it's only going to last as long as the stimulation's on for. So once the stimulation comes off, the nerves will eventually kind of get themselves back to where they were, and if the pain stimulus is still there, the pain will come back. So that's just another form that will get utilized with pain relief. Okay, so here we're looking at the kind of the diagram of your your descending level 2 pain control. And this is going to utilize your noxious pain modulation. So again, as we said, the key here is stimulation of the C fibers. So we're using here either a long phase duration stim, some form of stimulation where we could take the phase duration and increase it, or this also occurs with cryotherapy. As we talked about with cryotherapy, you do experience those aching and stinging sensations, and that is, again, stimulation of C fibers. So technically you do have that mechanism occurring there as well. So you stimulate those C fibers. What that does is that information goes up into the brain stem. You have your periaqueductal gray area, your pons, and your raphe nucleus, which are all structures we've talked about before in the brain stem and how they modulate pain. This produces the release of serotonin. So serotonin gets released, and what that does is it produces an inhibitory effect back down at the dorsal horn of the spinal cord. So again, the block here still occurs at the dorsal horn of the spinal cord. It just occurs via a different mechanism. It's now occurring because we're sending information down from the brainstem to come down. You're also getting enkephalin release, so the enkephalins will still get released, which will also produce a blocking of that pain signal. And you think about the importance of serotonin. A lot of times when patients have very complex pain problems, many times physicians will actually prescribe medications that will increase the levels of circulating serotonin to help with that. So obviously we're doing it through the use of a physical agent in the case, the two examples that I had given. Also some other forms of manual therapy. Most of your forms of massage or any type of soft tissue technique that induces some level of discomfort will also produce this specific effect. You're looking at this, there's a lot going on, but I'll kind of summarize some things for you and kind of show you what's basically happening. So, don't panic looking at the picture. Obviously, again, you should be able to recognize at least some of these structures and kind of understand what they're doing. I know it's a lot going on, but just kind of follow what I'm going to talk about here, and hopefully that makes it. So if we kind of look at this now, again, the key here is primarily stimulation of the A delta fibers. Now, obviously, the C fibers still get involved with this, and that's why it's sometimes hard to completely separate the two types of pain control, the level 2 and level 3. But this level 3, this rhythmical, or what's also known as beta endorphin pain control, you're primarily looking to get the A delta, but the C fibers will get involved. So essentially both fibers are going to be stimulated, but unlike level 2, now you're actually getting the A delta fibers more involved. Now the idea here is that you're actually going to produce what are known as, again, your beta endorphins. So these beta endorphins are naturally produced in various areas of the brain, and they affect the body kind of systemically. So there's a little bit more of a systemic pain relief that's going to occur with this, which is part of the reason for the more long-lasting effects of it. Again, this type of pain relief is known to last, upwards to, in some cases, to 6 hours. So the idea here is that you have your physical agent that will stimulate the A delta fibers, and by virtue of stimulating those A delta fibers, you're going to stimulate areas in the supraspinal region and also other areas of the brain. You see also here you have the hypothalamus and the pituitary. So there's actually other hormone responses that happen here as well. So the pituitary gland is actually going to get stimulated by virtue of the fact the reticular formation is. And in addition to assisting the body with producing beta endorphins and releasing those, causing more serotonin to get released in addition to just the circulating beta endorphins, but it also has an effect on the adrenal glands. So, if you go back to, what was discussed in some of your previous classes and even in anatomy and physiology, the pituitary gland releases what's called adrenocorticotrophic hormone, ACTH, which stimulates the adrenal glands to release cortisol and your corticosteroids. So corticosteroids are also going to provide an analgesic effect as well. So you see you have a much more, if you will, systemic pain relief coming from this, more though than specifically just intervening at the spinal cord. So this has a much greater effect systemically, which is part of the reason why you get more sustained pain relief through this mechanism. Okay, so again, the key here is stimulation of the A delta fibers. You still will get descending effects with this because the C fibers are likely going to be stimulated as well. So you'll get the effects of the beta endorphins coupled with the descending mechanism. So you'll still have serotonin getting released with this as well. And again, the way this is going to typically happen, and again, I'm not so much concerned that you know in depth now because obviously we haven't talked about stim yet, but a low frequency, high intensity stim, which will produce a muscle contraction, will produce this effect. And that's the key with that. It just, so basically what you need to do is some type of rhythmic, strong contraction that will stimulate the A delta fibers and therefore produce this sequence of events where you get the release of beta endorphins systemically, and you also get the adrenal glands to produce cortisol and your corticosteroids, which will further act. So here you're getting enhancement of not only your neural structures regards to pain relief, but you're also stimulating the pituitary gland and a lot of the hormonal and analgesic properties of the body that further help to reduce and decrease pain. Okay, now we'll talk a little bit about just some general things about treating persistent pain, because again, a lot of times we look at, acute pain for the most part, we understand the cause, we know what happens, we kind of understand in general how the healing process occurs. So it makes that a little bit easier to deal with. Whereas when you're talking about persistent pain, it gets a little more complicated. So really important, requires a slightly more in-depth evaluation, and you have to also look at the person's health history as well. Okay, so we may potentially have to look at what are some other health things that could be causing the persistent pain, because obviously we don't want something to be masked as an orthopedic injury when we're dealing with something that isn't. We also have to understand that the source of dysfunction may be distant from the location. So you may have to look at possible referred pain patterns. You have to look at biomechanical causes. Again, this isn't going to be a one-time acute traumatic event. It's going to be the person that comes to you and will say, my shoulder's been bothering me. They may have an idea about when it started, but for the most part, there's not that one incident that caused it to happen. And again, make sure you take your physical exam and contextualize it with the working diagnosis. So again, you're going to kind of be looking at other causes and maybe other areas of the body when you're looking at this. Now, if someone has had the problem for a while, their failure to improve may provide some useful information. So there may have been a diagnostic error in the past that caused this. So it's important to see, have they been treated for it? If they've been treated for it and the treatment has failed, it may kind of tell you, may kind of rule out some other things that maybe you actually thought were the problem, or someone else thought was the problem, and now you can kind of look at that as well. Okay, so anytime symptoms persist, or you have an injury that occurs in an absence of a specific trauma, or something unrelated to what we think of with inflammation. So again, these are your things like your tendinopathies and things like that don't follow classic repair guidelines, that you have to kind of look at, again, things like biomechanical causes and things like that. And it's really important to understand that with this, the person's going to have some central sensitization of pain. So in other words, what's going to happen is that, again, sometimes the longer this continues to persist, as we had talked about with pain, the longer those pain signals are being transmitted, it's going to kind of impact their pain experience a little bit more. And again, the dorsal horn of the spinal cord is going to allow more pain information to be getting sent, and that's going to make the pain more and more difficult to treat. And again, as I had previously said, consider other sources. So consider things possibly like a complex regional pain syndrome, a somatization issue, depression, rest re-injury cycles, things of that nature when you're looking at this.